Sir.
May I invite Dr. Sreekumar, please?
Good afternoon, everyone. Now let's go to the very basics of hernia surgery. I'll be just briefly telling you about the anatomy because most of you will be quite familiar with the boundaries and contents of the canal, such things, and I'll focus more on inguinal. This is the good diagram about the inguinal canal, and this is the anterior view where you get the direct hernia and indirect hernia and also the femoral hernia. This is an anterior view. This is a posterior view, and you get you see the medial ligament and the lateral ligament, and in the lateral fossa you get the indirect hernia, and in the medial fossa the direct hernia, then supravesical and femoral hernias. And these are the triangles about which you must be quite familiar, those who do laparoscopy regularly, the triangle of doom and triangle of pain, and collectively known as quadrilateral of disaster. And from behind you can see the sites of direct, indirect and femoral hernias also. And a word about the corona mortis also. It's an abnormal communication. The inferior epigastric artery, in 25 to 30% cases, it can replace the obturator artery and can cause torrential bleeding from the neck of the femoral hernia, and that is known as the corona mortis. Now, I would like to tell you about the concept of the secondary rings. Apart from the regular external ring, the secondary external ring is a tube-like arrangement of the Scarpa's fascia a little down, and that is the entry into the scrotum. A hernia becomes a scrotal hernia when it passes the secondary external ring. Adhesive obstruction can occur there, which can be a cause for undescended testis. And the secondary deep ring, it is actually deep to the regular deep ring which we get in the transversalis fascia. This is in the membranous layer of extraperitoneal fascia, and that should be the correct site of ligation of the indirect sac. Actually, the gonadal vessels and the genital branch of genital femoral enter into it at the site of the secondary deep ring. So you have to open the internal spermatic fascia properly to identify and isolate the sac and ligate that there. Now telling about the neuroanatomy of the inguinal region, the three familiar nerves, ilioinguinal nerve, the lateral entry through the transversus abdominis, then it follows the spermatic cord from the deep ring to the external ring, and then it gives off branches, cutaneous branches to the thigh, anterior scrotum and labia. It is seen on the superior aspect of the spermatic cord, usually. The iliohypogastric nerve is actually seen in the conjoined area. When we raise the upper flap of the external oblique aponeurosis, it is seen in between the internal oblique aponeurosis and external oblique aponeurosis. And there is motor to the internal oblique and transversus abdominis muscles, and it is sensory to the skin of posterolateral gluteal region and suprapubic region. The genital branch of genital femoral nerve in the pelvis, it follows the gonadal vessels to enter the inguinal canal deep to the lateral crus of deep ring. And in the spermatic cord, it follows the cremasteric vessels. So it is seen actually posteriorly. The blue line of the external cremasteric vein can be a pointer to the genital branch of genitofemoral nerve. It supplies the scrotal skin, cremaster, mons pubis and labia. And in laparoscopic surgery, generally these three nerves are not handled. The femoral branch of genitofemoral nerve and the lateral femoral cutaneous nerve, which are both sensory to the anterolateral aspect of thigh, comes into view in the laparoscopic repairs. A most common nerve injury is actually in laparoscopic surgery. It's entrapment of the lateral femoral cutaneous nerve of thigh in a tacker, which causes pain and numbness in the upper and lateral thigh. That's known as meralgia paresthetica. Now, the chronic groin pain or an inguinodynia. What is it? The moderate to severe pain lasting for more than 3 months after a hernia repair. It is actually an underreported problem in India, and it has become one of the very common reason for litigation in the West. The incidence is 6 to 8%, and it can be reduced to 1% by identification of the nerves and their protection from direct contact with the mesh. The symptoms are just like groin pain with radiation to scrotum and femoral triangle. It can be a dull ache to sharp shooting pain. There can be paresthesia, hyperalgesia, or allodynia. The pain is triggered by walking, twisting, and hyperextension of the hip, and it is relieved by rest and flexion of the hip. How that occurs? Perioperative nerve damage is one of the common reason, maybe a traction injury, or then the postoperative fibrosis, mesh-related fibrosis, or nerve entrapment in sutures or staplers. Sometimes periosteal reaction from the sutures, especially over the pubic tubercle. And ligation of the highly innervated peritoneal sac is also said to be a cause for groin pain. So some people advise not to ligate the sac, just put it back into the peritoneal cavity and do the repair with the mesh. How to prevent that? Iliohypogastric nerve is actually identified between internal and external oblique aponeurosis during the flap raising. If that nerve is, the general principle is better not to bear the nerve. Let it be inside its sheath, so that even if there is a contact with the mesh, that may not induce fibrosis. And if it is standing against the superior border, just like the lateral fishtailing, give a cut, a slit on the superior aspect also to accommodate the iliohypogastric nerve. Only 2 or 3 sutures need to be placed superiorly. 1 to the rectus sheath, 2 to the internal oblique aponeurosis, not to the muscle. Because the intramuscular course of the iliohypogastric nerve is the culprit. That is, many a time we miss that intramuscular part. So the lateral tail, the fish tails also, if you put a suture into the internal oblique muscle, that can cause entrapment of the nerve and inguinal. Then when we elevate the cord, regarding the ilioinguinal nerve, when we elevate it, blind elevation with the finger, index finger and the thumb sometimes causes this problem. So a proper dissection has to be done in the avascular planes, and the ilioinguinal nerve and genital branch of the genitofemoral nerve together should be lifted off from the floor. And when we repair, the external ring should not be too small, so that that will cause constriction of the ilioinguinal nerve. The genitofemoral nerve is protected by the deep cremasteric fascia, so better to avoid dividing the cremasteric muscle. And the vas deferens, the paravasal nerves, it is the sympathetics from the hypogastric plexus is around that. So if the vas deferens is bared, that can be a reason for orcalgia. And by chance, if a nerve is transected, it is better you ligate the end and implant into a muscle. Lightweight meshes and glue fixation of the mesh are being tried nowadays, which can, with no sutures, and also the future may be self-gripping absorbable meshes, which is not at all inducing fibrosis. What I have to say is inguinal is always better prevented than treated. Thank you.
Thank you, sir, for the excellent disposition of inguinal anatomy and measures to prevent inguinodynia. Sir, in your experience, what will you do when you get an inguinodynia, for example, after 6 months, continuous pain? What is your way of treating such patients?
In fact, I haven't had to do the surgery, but the description are you have to go for a triple neurectomy. That is a surgery to be done by real experts. We have to ligate all the 3 nerves away from the site of previous repair and fibrosis, and tie the ends and implant it into some muscle. And also laparoscopic implantation of some nerve stimulators above the quadratus and psoas is also described, which can also decrease the pain of inguinodynia.
Any questions from the floor? Okay, sir. Thank you very much.